Okay, well, we might make a start. Many people have come online, but there'll be some others who come in as we go. Look, today I wanted to talk about fluid and electrolyte management in pediatrics. It's a really common problem. We deal with this every day. It's a common management problem, and we need to be experts in this area. I wanted to break the talk up into a number of different parts. I'm going to talk a little bit about the physiology of fluid and electrolyte management and fluid and electrolyte physiology within the body, particularly talk about the different water compartments in the body. I'll say something about anti-diuretic hormone and something about the renin-angiotensin system, because they are involved in the regulation of fluid and electrolyte physiology, and we need to know about them. I want you to be really good at the calculation of fluid replacement in children with dehydration, and that involves knowing what the child's maintenance fluids are, what their deficit is, and what their ongoing losses are. And from that, you can calculate the hourly maintenance or the 12-hourly maintenance, and you can then prescribe fluid replacement accurately. We'll say something about hyponatremia and hypernatremia, because they're two electrolyte abnormalities that have a lot of implications for how children do when they're very sick. And I'll say something about fluid boluses and shock, because there's a lot of, it's a controversial area, I'd say, and we just need to have an approach to whether or not to give fluid boluses to, or who to give fluid boluses to. So that's the outline of the talk. Let's talk first about a bit of physiology. So there are two main compartments of water in the body, two main ones, and these are the basic things you need to know. Firstly is the intracellular water, and then there's the extracellular water. And of the extracellular water, some of that fluid is intravascular, as in the blood, inside the blood vessels, or in the it's the blood volume, and some of it's interstitial, which is between the cells. So that's the extracellular fluid. In an adult, about 2/3 of the adult's weight is water. It's a bit more in children and quite a bit more in neonates. And the smaller a neonate is, the higher proportion of their body weight is water. And in an adult, about 1/3 of the total body water is outside the cells, and about 2/3 of it is inside the cells. And of the fluid outside the cells in the extracellular water, about 1/3 of that is in the intravascular volume. So just the main thing is to just know that there's intracellular and extracellular, and of the extracellular, there's intravascular and interstitial. These are the body water compartments. As I mentioned, in adults are a lower proportion of their body weight is water. So in an adult, it's about 600 mils per kilo, or 60% if you like, because in a kilogram, there's 1,000 mils of water. So an adult is about 60% water, and a neonate, especially a premature neonate, is about 80% water. And most of the difference is in the extracellular fluid. That is, a neonate in the first week of life has more extracellular fluid. And that's why small babies in the first week of life often lose about 10% of their birth weight in the first week. What they're losing is extracellular fluid. Neonates also have higher blood volume, a higher blood volume in terms of mils per kilogram. So the adult blood volume is about 70 mils per kilogram, and so in a standard 70 kilo adult, the blood volume is about 5 litres, and it's proportionately similar in neonates and young children, although the total blood volume is a little bit more. So if you had a 5 kilo infant, for example, then their blood volume is around about 400 mils. 400 mils being about 85 mils per kilo. So 85 times 4 is about 400. Okay. Neonates have a higher extracellular fluid, and that is, they have more interstitial fluid and a higher blood volume. They're proportionately, their intracellular water is about the same. and infants and children are somewhere in the middle. They're transitioning from like a premature neonate to a neonate to an infant to a child in terms of this loss of extracellular fluid that characterizes the excess that occurs in neonates. I want to say something about antidiuretic hormone, and sometimes this is a little bit hard for people to understand, but there's some basic things that you need to know about ADH, antidiuretic hormone, and they have a lot of implications for pediatrics. So the main things you need to know are that antidiuretic hormone is produced in the posterior pituitary, so in the brain. We've talked about that before, actually. It's in the posterior pituitary, and antidiuretic hormone is released to maintain blood volume and to correct hyperosmolarity. So when there's reduced blood pressure or reduced plasma volume or increased osmolarity, that is, there's a hyperosmolar state, then you'll get more antidiuretic hormone being produced. And what that means is that the kidneys, the renal tubules, they absorb more water. That's all in the collecting duct. And so the stimulator ADH, we all have ADH, antidiuretic hormone circulating. Most of us don't have much, but under some conditions, we can have an increase in the ADH being produced by the posterior pituitary. And the stimulator increasing it are a reduction in blood volume or a reduction in blood pressure. So if a patient's hypotensive, they'll have a lot more ADH. And if they have hyperosmolarity, like they have high levels of serum sodium, for example, then they too will have high levels of antidiuretic hormone. That's the normal stimuli to antidiuretic hormone secretion. And all that does is stimulate the collecting ducts of the renal tubules to absorb more water, and that is less urine is passed, and that can, because you absorb more water, that corrects the hyperosmolarity, and because you're absorbing more water, you're correcting the hypotension or the hypovolemia. All right, so it's a very important defense against hypotension and hyperosmolarity. But there are some conditions in children, particularly where you have high levels of circulating antidiuretic hormone, and it's not entirely clear why, but they have some protective advantage. And so if a child has meningitis or pneumonia or bronchiolitis or sepsis, then they will have high levels of circulating antidiuretic hormone. And I always think of it like this, that in the past, patients who had severe pneumonia or severe meningitis, they didn't get much fluid. They might have been sitting or lying at home for several days, getting sicker, and they couldn't drink much because of their respiratory distress or because their conscious state was poor. And so having high levels of antidiuretic hormone allows them to retain water and not become dehydrated. So these days, this condition called SIADH, or syndrome of inappropriate antidiuretic hormone, characterizes some children who've got meningitis or pneumonia or bronchiolitis, and all it means is that they don't pass much urine, but they can maintain their blood volume. And sometimes if we give them the wrong fluid, then they'll get hyponatremic. Their serum sodium will drop because they've got high retention of water. Right? They can't pass much water because their ADH levels are high, and so they retain water, and that dilutes their serum sodium, and their sodium level drops. Okay. There are some conditions in which you have reduced ADH secretion. So if you've got hypoosmolarity, that is the hyponatremia or a very dilute serum, then you'll have low levels of antidiuretic hormone. There are some pathological conditions that where you have ADH insufficiency, like diabetes insipidus, which can be central, as if you've got a problem with your posterior pituitary, such as with a brain injury or cerebral ischemia, a stroke, or even post-TB meningitis. Sometimes children have diabetes insipidus of a central or neurogenic origin, that is central brain or neurogenic origin. And there's some children that have resistance to antidiuretic hormone at a collecting duct level. So they'll have what's called nephrogenic diabetes insipidus, or they'll have ADH resistance. So their posterior pituitary might be producing enough ADH, but their kidneys can't react to it. So therefore, they will have low levels of antidiuretic hormone and they'll become hypotensive because they can't retain fluid. But the main thing I want you to know about is the stimuli for ADH, the low blood pressure, low plasma volume, high osmolarity, and the conditions under which a child may have what's called inappropriate ADH secretion, such as meningitis or pneumonia or bronchiolitis or sepsis, or sometimes just after surgery. Anesthetic drugs, nausea and vomiting can cause high ADH secretion. And these have a protective advantage to the patient. The second mechanism I want you to know a bit about is the renin-angiotensin-aldosterone system. And I know you've learnt this in basic science, but it's good to revise it, I think, when there's a clinical relevance. And there is plenty of clinical relevance around renin-angiotensin-aldosterone these days because of the different drugs that can modify the renin-angiotensin-aldosterone pathway. And just to know that renin is produced under conditions a bit like ADH. It's produced under conditions of low blood pressure or low cardiac output. So if the blood pressure is low or the cardiac output's low, then that stimulates the kidney to produce renin. And renin itself isn't very active, but it gets converted into angiotensin, and it's converted in two stages, angiotensin 1 and angiotensin 2. And the only reason why it's useful to know these two stages is that there's different enzymes that convert renin into angiotensin 2. And one is produced in the liver called angiotensinogen, and the other one, which you'll know about, is called angiotensin converting enzyme, and that converts angiotensin 1 into angiotensin 2. And this angiotensin converting enzyme is quite an important enzyme because it can be blocked by ACE inhibitors, for example, captopril and enalapril. So if you think about what this would do, it would actually block the effect. The ACE inhibitors will block the effect of the renin-angiotensin system, and so therefore they're likely to cause hypotension, which we see with captopril, of course, don't we? We see vasodilatation and hypotension. And the reason why we get significant vasodilatation with ACE inhibitors is that angiotensin 2 is a very potent, probably the most potent vasoconstrictor in the body. All right, it's a strong vasoconstrictor, and it also can reduce urine output, so you retain more water and you reduce glomerular filtration rate, so less blood flows through the kidneys, so the kidneys make less urine. And all that does is it props up the blood pressure. You get more retention of water, more vasoconstriction, so the blood pressure is increased because of salt retention and water retention. Angiotensin 2 is not only a strong vasoconstrictor, but it also stimulates aldosterone production by the adrenal glands, and aldosterone, that acts directly to retain salt and water. So both ADH, antidiuretic hormone, and the renin-angiotensin-aldosterone system have complex mechanisms to retain water, to improve blood pressure, to retain sodium, to cause vasoconstriction, to improve the cardiac output. And so when you've got a situation of hypotension or hypovolemia, dehydration, hypovolemic shock, you'll have high levels of renin-angiotensin-aldosterone and also antidiuretic hormone, usually in most cases. I wanted to talk briefly about the calculations of water, electrolyte, and energy, because I think we need to be, again, the clinical application is we need to be able to calculate the amount of fluid that a patient needs. And I know you know the 150-20 rule and the 4-2-1 rule. I just want to go over them again because I think it's useful to revise. And I've described in this table how you calculate the 150-20 rule. So if you think 150-20 rule is the amount of water in mils per kilogram per day a child needs. And the 4-2-1 rule is the amount of water in mils per kilogram per hour that a child needs, right? 150-20 mils per kilogram per day, and the 4-2-1 rule, mils per kilogram per hour. And so for a patient who weighs somewhere between 0 and 10 kilos, then it's 100 mils per kilo per day. That translates to 4 mils per kilo per hour, because that's every hour, that's 4 mils per kilo per hour. So if you've got a 6 kilo child, they'll get 6 times 4, that's 24 mils per hour. And if they're a 6 kilo child, throughout a whole day, they'll get 600 mils. It's roughly the same thing. But whether you want to calculate it in terms of mils per kilo per hour because you're regulating a drip, or you want to calculate it in mils per kilo per day because you're trying to calculate the total fluid intake a child should receive for a 24-hour period, then you can use one of these more or less equivalent formulas. If the child's more than 10 kilos, it becomes a little bit more complicated. That's where the 50 rule part of the rule comes in, and the 2. So 4-2-1 or 150-20, right? And that means if a child is, say, 12 kilos, then it's 1,000 mils. So 100 mils for the first 10 kilos, 100 times 10 is 1,000, plus 50 times for the next 2 kilos, for example. So that's an extra 100. So that'd be 1,000 plus 100, right? And the same for the 4-2-1 rule. It'll be 40 plus 2 times the number of kilos between 2 and 20 kilos. So that's 2 times 2. So that's another 4 mils. So it'll be 44 mils, for example. If a child weighs over 20 kilos, then it's 1,500 mils. This total here for 20 kilos plus 20 mils per kilo for every kilogram above 20 kilograms. And the same with the 4-2-1 rule. It's 1 mil per kilo for every kilogram above 20. So it's 40 plus 20 plus whatever the number of mils is above that. So if you've got a patient who's 25 kilograms, then they'll get 1,500 mils plus 20 times 5, which is 100. So that's 1,600 mils, and that's per day. Or they'll get 60 mils plus 5 times 1, which is 65 mils per hour. And that roughly equates to 1,600 mils per day. So as I say, when you are calculating the amount of volume per hour by drip, or calculating it in terms of the amount of rehydration you're giving by nasogastric tube or by enteral feeding, then you can work out per hour or per day, and it's the same thing. I've written here the amount of millimoles per kilogram per day of sodium that is roughly needed for most children for growth and for normal metabolism, and the amount of potassium that children mostly need for growth and metabolism. And that differs, of course, if patients have dehydration, or if they're vomiting, or if they're on diuretics, they may have different potassium and sodium requirements. But this is what is needed in terms of normal physiology. And it's more in the first 10 kilos, less in the next 10 kilos, and even less in the 10 kilograms or the kilograms after 20 kilos. And similarly for glucose, more glucose is required for the first 10 kilos, a bit less for the next 10 kilos, and beyond that, a bit less. The way we calculate energy requirements is more or less the same as the 150-20 rule. And this is in a way how the amount of energy and water a patient requires is calculated. If you think about the 150-20 rule, you can apply that to the amount of energy or calories, kilocalories per kilogram per day a child needs. If you want to do it in kilojoules, that you multiply it by 4.18 will give you the number of kilojoules. So that's 400 kilojoules per kilogram per day. But mostly I old-fashioned, I keep going 150-20 of kilocalories per kilogram per day. Okay, so just to do an example of the 150-20 rule or the 4-2-1 rule, let's do that in terms of a different weight. So a 17 kilogram girl will need 100 mils for the first 10 kilos, that's 1,000 mils. She'll then need 50 mils for the next 10 kilos, and she's 7 kilos above 10 kilos, so that's 50 times 7, so that's an extra 350 mils. So the total will be 1,350 mils in 24 hours, or you can divide that by 24 and get 56 mils per hour. Okay, and if you worked out the 4-2-1 rule, it'd be roughly similar. And a 35 kilogram boy, for example, will need 100 mils per kilo for the first 10 kilos, so it's 1,000 mils, and then 50 mils per kilo for the next 10 kilos, that's another 500 mils, and then 20 mils per kilo for the next 15 kilos, so 10 plus 10 plus 15 is 35, so that'll be an extra 300 mils, and that gives a total of 1,000 plus 500 plus 300 is 1,800 mils in a 24-hour period. And you divide that by 24 and you get 75 mils per hour. All right? So it's really important that you don't think, well, 100 mils per kilo per day for all weights, because if you think about it, that would be 100 mils per kilo would be 3.5 litres per day, where the real maintenance fluid is only 1,800 mils. And that shows you that as children get bigger, they proportionately need less volume. All right, so it's not 100 mils per kilo endlessly, because that would mean 3.5 litres. In a 35 kilo child, it's only 1,800 mils in 24 hours. Now, it's important to note that volume that I've described, that you work out with the 150-20 rule or the 4-2-1 rule, is the maintenance fluid. And the maintenance fluid is really the fluid volume required under normal conditions, right? Not conditions where a child's sick. And this is very important, because if we give that much volume to a child who's sick, if we gave that much volume intravenously, then almost all children who are sick will actually become edematous. This is really important. I see this very often, that children become edematous because they get their normal maintenance fluid. And mostly that's because they have high levels of ADH, antidiuretic hormone, because they're physiologically, they're adapting to their illness, they're retaining water, and we go on and give them 150-20 or their normal maintenance fluid, and that causes them to be edematous. And the normal maintenance fluid is really the amount of water that's required by a normal child who's running around and playing normally and metabolizing normally. And that enables them to excrete all the solutes they produce, all the urea and the creatinine that their body produces through metabolism, and the electrolytes they need to excrete. It allows them to produce that excess solutes in a not too concentrated and not too dilute urine. And this is important, because if you've got a patient who's got high ADH, they'll only be able to have a very concentrated urine. They can't produce a dilute urine. And so they won't be able to excrete all of those solutes. They won't be able to excrete all those solutes, so they'll retain more water. And if we give them 150-20, then they'll become fluid overloaded, because their kidneys, for a period of time, for the acute phase of the infection, the meningitis or the bronchiolitis or the pneumonia, their kidneys are not able to excrete that much, what we call free water, that much water. All right, so I want to talk a bit about rehydration. So, because I think we need to be experts in the calculation of fluid replacement for children. I've talked about maintenance fluid and how you calculate that, the 4-2-1 rule. When you're thinking about rehydration of a patient, you need to think about three things. Firstly, the maintenance fluid a child needs. Secondly, their deficit, right? And thirdly, their ongoing losses. So when we're talking about maintenance fluid, we already talked about the maintenance fluid 4-2-1 rule. That's mils per kilo per hour. And then we need to think about the deficit. If you look at this child here who had severe diarrhea for several days before he presented, how dry do you think he is? Yeah, he's very dry, isn't he? He's very dehydrated. You can see that he's got sunken eyes. He's got a scaphoid abdomen. He's got a very doughy looking feel to his abdomen. He looks profoundly lethargic, isn't he? He's just lying there very floppy. He's lying in a sort of floppy position. He's got very poor skin turgor. So this boy has got to be 10% dehydrated. And so the percentage, we need to estimate the percentage of body water loss. And that's dependent on whether a child is mild, moderate, or severely dehydrated. This child is at least 10% dehydrated. So that means they've lost 10% of their body water. Right? And we base that on clinical signs of dehydration. The more signs you have, the worse those signs are, the more dehydrated you are. If you're only 5% dehydrated, then most children, they just have thirst. They don't have signs of dehydration. They have thirst, they might have dry mucous membranes, but that's all. They won't have sunken eyes, they won't be lethargic, they'll just have thirst, and you give them something to drink and they'll just drink it. They'll drink it willingly. Their conscious state's normal, for example, but as they get more dehydrated, if a child is more than 10% dehydrated, like this child here, then they'll become lethargic, they'll become less conscious, they'll have sunken eyes, they'll have dry mucous membranes, they'll have tachycardia, they'll have poor capillary return, they'll have very poor skin turgor, they'll have rapid and weak pulses, etc. So they'll have more signs of dehydration, and they'll be more severe than if you've only got mild dehydration. For most children who have vomiting or diarrhea, when we are calculating the rehydration, we need to make some allowance for ongoing losses. Because if a child's got profuse watery diarrhea and they come in with, say, 10% dehydration, and all we do is replace their maintenance and their deficit, if they've got ongoing losses, they may still get behind in terms of their fluid losses. So what I usually do is simple. I just ask the parents, how many times has the baby had diarrhea in the last 6 hours? And if, for example, the baby's had 4 lots of diarrhea in the last 6 hours, then I add 4 times 50 mils as part of that. I'll explain the calculation, but you just need to add a bit more for ongoing losses. If they're over 2 years of age, I usually add 100 mils per diarrheal stool. So you might ask them, how many times have they had diarrhea in the last 6 or 12 hours? Let's say 12 hours. And if they've had 4 or 5 episodes, then you add an extra 500 mils for ongoing losses. Because you can imagine sometimes the diarrhea stops when you start rehydrating patients, and sometimes it continues, and you don't want children to get behind. I'll talk a bit more about correcting shock a little bit later. Usually, I replace the deficit. The principles are that I usually replace the deficit over 12 hours. Now, some people replace it slower than that. The reason I replace the deficit over 12 hours is because I think it's important to keep reassessing your patients. So I always come back at 6 hours to see how rehydrated they are, and then come back at 12 hours and see if they're fully rehydrated. If you calculate to replace their deficit over 24 hours, then sometimes you don't have a chance to reassess properly, because the next time you see them, it is a day later. And I think it's not good for a child to be dehydrated for a whole day. In some places, you'll hear about rapid rehydration, like children being rehydrated in 2 to 4 hours. I think that's in general a bit fast, and it can run into some problems. So I typically calculate the deficit to be replaced over 12 hours. But in that 12 hours, remember, you've got to give the maintenance fluid a child needs, and you've also got to give some fluid for ongoing losses. So it's more than just replacing their deficit over 12 hours, because the maintenance and the ongoing losses have to be added onto that. Here's an example I want to go through. So a 14-month-old boy, this was the boy I showed you in the picture before. He had 3 days of vomiting and diarrhea. And he came in, you can see in that picture, he was lethargic, he had sunken eyes, he had poor skin turgor, he had cold limbs, and his weight was 9.2 kilos. And you, as I said, you can see that this boy is at least 10% dehydrated. So 10% of 9.2 kilos, 10%, remember 9 kilos of 9 kilograms is 9,000 mils of water, right? 9,000 mils. So 10% of that is about 900 mils. So you can calculate this boy's deficit as being 900 mils. This boy has severe dehydration, he would have lost at least 900 mils in the 3 days that he had diarrhea. And you, as I said, you want to replace that deficit, I think, over about 12 hours. So you divide 900 mils by 12 and you get 75 mils per hour, right? The maintenance fluid for this boy is 9.2 kilos times 100 mils per kilo per day, or 920 mils per day. And you'd replace that, of course, over 24 hours. So that means an extra 38 mils per hour. So for the first 12 hours, he needed at least 75 mils plus 38 mils. 38 mils an hour for his maintenance and 75 mils an hour for his very large deficit, right? And then you might say, well, we need to add something for ongoing losses. So this boy had 4 diarrheal stools in the last 12 hours. So that's 4 times 50 because he's under 2 years of age. So roughly an extra 200 mils. So 4 5s are 20, 200 mils. And you divide that by 12. So that's an extra 17 mils an hour. So it's a reasonable amount of volume, isn't it? It's not, if you missed that ongoing losses, then the child could get further dehydrated. So the total over the first 24 hours is 75 mils of deficit plus 35 mils an hour of his maintenance plus 17 mils an hour for ongoing losses. So that adds up to 130 mils an hour for the first 12 hours. And you can come back in 12 hours time and assess whether or not you've calculated properly and you've rehydrated the child properly if you gave 130 mils an hour. And if you came back in 6 hours, then you should be starting to see the signs of dehydration resolve. In reality, you'd probably be assessing this patient every hour for the first few hours, because you won't really want to know that his severe dehydration is improving, that he's not having ongoing diarrhea and vomiting, that his conscious state's improving. But you would imagine that this boy would need about 130 mils an hour for the first 12 hours. Okay. It's always safer to give enteral fluid rehydration than it is to give IV rehydration. And I guess in patients with severe dehydration, sometimes they will they need intravenous rehydration. Often they need IV rehydration. If they've got moderate dehydration, somewhere between 5 and 10% dehydration, then oral rehydration solution is just as effective, and it can be effective if you give it down the nasogastric tube, for example. Enteral fluid or enteral rehydration avoids getting nosocomial infection from IV drips and electrolyte disturbance, because usually the gut is able to absorb the electrolytes and water and glucose and nutrition. If you give enteral fluid, it provides some nutrition. So as a principle, for children who've got vomiting and diarrhea, if they've got gastroenteritis, try to keep them enterally feeding, especially if they're breastfed. Definitely they need breastfeeding, and they may need some extra oral rehydration solution, or if they've got severe dehydration or shock, they might need intravenous fluids. But you should remember the benefits, I suppose, of enteral feeding to the gut, the gastrointestinal tract, to the gut. It maintains peristalsis and maintains the mucosal integrity of the gut. If you don't feed a patient for a couple of days, then what happens is the lining of the gastrointestinal tract starts to erode, and that can increase their risk of sepsis. They get bacterial translocation across the bowel wall into the bloodstream, and they're much more at risk of pneumonia and bacteremia than if you can keep some nutrition going. It also produces gastric protection, so that a child who's fed is not likely to get a gastric ulcer, and it reduces constipation. If you don't feed patients for several days and they're sick with some severe infection, then they're likely to get very constipated. And so if you feed patients, you can keep their gut working. You need a healthy gut, and you need to keep feeding patients if you possibly can. And if it has to be down a nasogastric tube, then that's fine. Okay. I wanted to touch on a couple of electrolyte complications because they're quite common, and I won't go into this in too much detail, except to say that one of the very common complications is hyponatremia. And when you look at different studies that have looked at common infections like septicemia or bronchiolitis or pneumonia or meningitis, then a high proportion of children have hyponatremia, like low levels of serum sodium at the time they present. And so, in some studies, particularly 2 studies in PNG, quite a lot of children have quite severe hyponatremia if they have pneumonia or meningitis. And they have that because they've got high levels of circulating anti-diuretic hormone. So they retain more water from their kidneys, from the collecting ducts in their kidneys, and that retains more water. They pass a concentrated urine, and their blood is a bit diluted for the acute stage of their infection with pneumonia or meningitis, and that's why they sometimes have hyponatremia. And depending on the type of fluid we give them, we can make this worse or we can make it better. And I guess I just want to cover this point off. So when we are choosing intravenous fluids, we choose the right intravenous fluid, the safest intravenous fluid for children. Of course, the safest fluid for children is enteral feeding, either enteral breast milk or enteral F75 or F100, or even oral rehydration solution. That's the safest fluid, but for some children who need intravenous fluids because they've got severe dehydration or they've got severe respiratory distress, then you need to know what's the safest fluid to give. And the hyponatremia can, I won't go into these studies too much, but hyponatremia can cause very severe complications. And this is a few years ago, we looked at all the children that had been reported that had very severe neurological outcomes from having hyponatremia. And these are case reports of children that presented with very severe hyponatremia. I've seen many of these kids present with severe hyponatremia, and they present with seizures or coma or cerebral edema, particularly status epilepticus. And it can be a very severe problem. So just know that hyponatremia is usually related to high anti-diuretic hormone, and it can be made worse if we give the wrong intravenous fluids, and it can cause severe neurological outcomes. So this is the CT scan of a child who had severe hyponatremia, and this was his CT scan, and you can see how swollen his brain is. Maybe you're not used to looking at the sagittal sections of CT scans, but his brain is quite swollen. He's got cerebral cortical and widespread cerebral edema with even some degree of cerebellar herniation through the foramen magnum. So this child has severe cerebral edema related to hyponatremia, and some children have even lower serum sodiums than that and have cerebral edema. This is the brain sections in post-mortem of a child who had severe hyponatremia, so a serum sodium of 119, and this is a child who died and had a post-mortem and had a normal serum sodium. You can see the difference, one where the brain is very swollen and the sulcal and gyral pattern of the brain has been lost by the cerebral swelling. It's the same as what you see on the CT scan. You can't see the normal sulcal and gyral pattern on the CT scan. This is a swollen brain related to hyponatremia. So we've got to do everything we can to avoid, to keep the electrolytes in the normal range, I would say. And we can do that by choosing the right intravenous fluids. And this was an issue in many countries throughout the world in the last 20 years. 20 years ago, we used to see a lot of severe neurological outcomes from hyponatremia, and part of that was related to the type of fluid that was given. I don't want to dwell on this too much, but it is important that we get that type of IV fluid right if we're giving IV fluids. And the biggest culprit, if you like, the biggest cause of this hyponatremia was the inappropriate use of what's called 1/5 normal saline, or 0.18% NaCl, 0.18% normal saline. This was a common fluid we all used to use. It was called 4.3% dextrose and 1/5 normal saline, and or 4.3% dextrose and 0.18% NaCl normal saline. And this fluid was used in all wards in almost all countries, but it was found in these case reports I described to be quite closely related to hyponatremia in certain conditions, like in pneumonia and bronchiolitis, in meningitis and encephalitis. So it's actually quite a dangerous fluid in patients who are at risk of hyponatremia. And so many countries had major inquiries. In Northern Ireland, there was an inquiry that stretched over 8 years. And in the UK, there was another inquiry. In Australia, there was an inquiry. And in Canada, there was a big coronial inquest that went for many years. And eventually, all countries banned the use of this fluid, 0.18% sodium chloride. And it's just important that we don't use that in patients who are very sick and at risk of hyponatremia. WHO has also recommended against using these types of fluids, hyponatremic solutions, right? And I think I've talked about this before in the last 15 minutes, but I just want to summarize here why some patients get serious complications from hyponatremia. It's because of this thing called SIADH. So the syndrome of inappropriate or high antidiuretic hormone. It's not really inappropriate, because we're giving those patients have ADH levels that are needed if you've got severe meningitis or severe pneumonia, and you're not getting no one's giving you extra fluid. But the inappropriate thing is when a doctor comes along and puts an IV drip in and gives that patient the wrong fluid and too much of it. And that leads to hyponatremia. The main implication is don't give too much IV fluids and don't give hypotonic fluids, especially in a child who's got meningitis or pneumonia. So when I'm thinking about the fluid requirements, not for a child with dehydration, but if you're thinking about how to calculate the maintenance fluid requirements of a child, then there are some conditions that I've talked about where you don't need to give the normal maintenance fluid. You don't need to give that much. And that's where you've got high ADH levels, high antidiuretic hormone levels. So if a child's got meningitis or pneumonia or sepsis, you must give much less than normal maintenance fluids. And if a child's unconscious, they'll have a low metabolic rate, they're inactive, they've got maybe their body temperature is not high, so they're not metabolizing at the same rate. And so they won't need as much water either. Or if a child's got, for example, reduced urine output for whatever reason because of high ADH, then they won't need as much intravenous fluids to maintain their normal hydration state. So for those children, they may need a half or 2/3 of their IV maintenance fluids. But for some children, they'll need an increased fluid requirement. So if they've got a high fever, they might need a bit more fluid. Or if they've got vomiting or diarrhea or tachypnea, they might need a bit more fluid. Or if they've got, say, appendicitis and they've got lots of third spacing losses within their gastrointestinal tract, then they might need a bit more fluid. And so we need to examine children for their signs of overhydration, normal hydration, or underhydration, and adjust their fluids accordingly. So you start with the 150-20 rule or the 4-2-1 rule, and then you either go up a bit or down a bit, depending on whether they have these signs, what their underlying disease is. I hope that makes sense. There's a variety of different fluids you can choose from. I've already said that this one up the top, 0.18% sodium chloride and 4.3% dextrose, is a fluid we just shouldn't use. It doesn't have enough sodium in it, only 1/5 of the normal serum concentration of sodium, and that can lead it can lead to water overload and hyponatremia in patients with high ADH levels. The sorts of fluids that are okay to give, particularly Hartman solution, that's a good fluid. It has a serum sodium that's roughly similar to the plasma, normal plasma, has a potassium level that's again roughly similar to plasma, has a chloride level that's roughly similar to plasma. It has enough glucose to stop most patients becoming hypoglycemic. It has a little bit of calcium in it, and it has some lactate in it. And lactate is an important element. It doesn't cause lactic acidosis. Lactate in Hartman solution gets converted by the liver to bicarbonate. So it's unlike normal saline. Normal saline is a acidic fluid. It's got a bit much sodium. It's got much too much chloride, and it's got a very low pH. It's quite an acidic fluid, whereas Hartman solution is not an acidic fluid. It's actually got a normal pH. So this is probably the best fluid to give as a maintenance fluid for children. Remember, it's got to be Hartman solution with some glucose. That's the only thing. This is Alexis Hartman. He was a pediatrician in the 1930s, and he discovered or made the first Hartman solution. And as I said, he was a pediatrician, and he designed this fluid as rehydration for children with severe dehydration from gastroenteritis. And he was trying to work out how to make a solution that wasn't acidic, whereas intravenous normal saline is very acidic because it's got lots of chloride in it. And it's not easy to do that because you can't just add bicarbonate to intravenous fluids, because if you do that, the bicarbonate will often coagulate in the intravenous drip lines. It'll cause, it'll combine with, say, calcium and lead to calcium carbonate, for example, and lead to sludging or debris in the intravenous lines. And so what he did was add lactate to the solution, presuming that if you add lactate and a patient's got a normally functioning liver, they will make bicarbonate in the body. So it's quite a clever solution that he came up with, where if you add some lactate to a solution, then you can have a solution that is not too acidic and doesn't have too much chloride in it. So that's Hartman solution. There are some other similar fluids that you might hear about. One's called Plasmalite, which is another solution that's a bit like Hartman solution, which is it's called a balanced salt solution. It's balanced in that it's similar to our normal body plasma. Right? Hartman solution, Plasmalite, they're two solutions that are similar to our normal body plasma. Half-strength Dextrose is a little bit different. It was made for rehydration, but it's only got half the amount of sodium compared with normal plasma. So again, that's not very ideal. It's quite good if you've got hypokalemia. If you've got severe potassium loss, then half-strength Dextrose can be a good solution, but you still have to watch the serum sodium and make sure the patient's not getting hyponatremic, because that can be a risk. I like Hartman solution as a rehydration solution if you have to use intravenous fluid, and as a maintenance fluid for patients who need it. So that's Alexis Hartman. He added lactate to what was called Ringer's solution. He made Ringer's lactate, which is otherwise known as Hartman's solution. Remember, he was a pediatrician. So the main take-home message is that if you give too much IV fluid and you don't take account of whether or not a patient's got high ADH levels, if you're not factoring in other fluids a patient's receiving, so sometimes we prescribe just their maintenance fluid, and we don't realize they get a lot of fluid when they get, say, intravenous drugs, antibiotics that are diluted in fluid. A child might actually receive a lot more fluid than you prescribe. And there are a number of reasons why children get a brain injury from IV fluids and hyponatremia, but we want to try to avoid that at all costs. Right? We should not allow patients to have complications from intravenous fluids like edema and cerebral edema particularly. So just to cover it off again, what volume of maintenance fluid? Well, often if you give the 4-2-1 rule, you'll overhydrate patients who've got high ADH levels. So I actually think that you should start with the 4-2-1 rule. We should teach our residents and our nurses the 4-2-1 rule, but you start with that and then start the fluid going as 2/3 or even half the maintenance. And for every patient, you should know what their TFI is for the day. You should calculate that when you're doing your rounds. You should work out what the best total fluid intake is for this patient today. And that should involve their IV fluids, their nasogastric fluids, their oral fluids, the drug flushes they're getting. So you just need to know their total fluid intake or how much you think they should have. Okay. Sometimes I've found that when you add up the drug flushes and the diluents for medications and maybe some blood products, that can add 50% to the TFI. So sometimes we overhydrate patients and we don't realize. So just be aware that you've got to take into account all the different types of fluid a child's receiving. Sometimes people want to know how to make up dextrose solutions. So this is particularly important if you're making up like 5% dextrose and Hartman solution or 5% dextrose with normal saline. Then what you do is you need to, if you want to make up a 5% dextrose, you have to dilute it at a ratio of 1:9. So for example, with 50% dextrose, so you can add 100 mils of 50% dextrose to 900 mils of Hartman solution, and that will make up a 5% dextrose solution. Why is that? Because 100 mils of 50% dextrose is 50 grams of glucose, and 50 grams of glucose per 1,000 mils is 5% glucose, right? 50 grams per 1,000 mils is 5%. That's how you make up a 5% solution. 50 grams of dextrose to 1,000 mils of fluid. Therefore, you need to add 100 mils of 50% dextrose, because 100 mils of 50% dextrose is 50 grams of dextrose. Okay. Excuse me. Hello, it's Trevor Duke speaking. Yes, mate. Yes, of course. Yeah. I'll be there in just a moment. Yeah. Let me just stop this. Yeah.